This week on the BackTable podcast.
I mean, it is not uncommon for surgeons to die younger than the general population because we've spent our lifetime taking care of other people, eating graham crackers and peanut butter in the surgeon's lounge and never getting outside before dark. So my suggestion is to get your own health in order. And in doing so, you will learn about the key elements that have saved your own life so that you can come at this with an authenticity that your patients will see.
Hi, folks. My name is Dr. Amy Pearlman. I'm a board-certified urologist with expertise in sexual, hormonal, and genitourinary health. And welcome to today's episode of BackTable Urology. I have a very special guest with us today, Dr. Vonda Wright, and she might be the first orthopedic surgeon we've had on BackTable Urology. Dr. Wright, please say hello to the crew.
Hi, doctors.
So it's so nice to have you here, and I've been watching you from afar for a while now, and without you knowing it, you've revolutionized my practice as well as my sister's practice. So I'd like to give the audience a little bit of an introduction here. Dr. Wright, she's a prominent orthopedic surgeon with expertise in sports medicine and has really delved into treating midlife women as they're going through perimenopause and menopause and really treating their muscle as medicine. So briefly, in terms of her education, she got her Bachelor of Science at Wheaton College. She then was a nurse, and she got her nursing degree from Rush University. And Dr. Wright, you worked as a cancer nurse in your early 20s.
I did. In 3 years after my undergraduate degree, I got another bachelor's degree and a master's, and first started on a cancer floor, but ended up in nursing as not co-running would be an exaggeration, but I worked directly with the chairman of the Rush Cancer Institute.
Wow. And before I get through the rest of your training, I want to kind of hone in on this area of your training for a little bit here, or of your professional career, because you mentioned that you were very impressionable, like we all are when we're in our 20s, and it really helps you become the empathetic surgeon that you are today. So what might your message be to other young people in their 20s? What types of experiences might they look for to help them become this whole person doctor that you've become?
So, I think that once you choose a track in medicine, that it is so intense and so expensive and such a fire hydrant of information that we can lose sight of what we're actually doing. We are not treating widgets. We are not mechanics. And although we will become masters of anatomy, what our true North Star has to be is becoming, I don't know what the description is, but maybe masters of trust. I mean, the fact of the matter is we're treating real people in the most vulnerable times in their lives, whether it's cancer or, as an orthopedic surgeon now, treating people whose entire future looks empty to them because of their severe injury. And we have to remember that it's not just about putting metal in bones in my case, or using the newest technology, which it is. We're all innovative technologists. But the reality is that my point of view, my expertise, the reason that I continue to be different than other people who educate publicly, and I say this to a bunch of surgeons, knowing that this number is not as high as some surgeons, but I've sat across the table and looked into the eyes of 100,000 people in my career because I sit down. I don't have a hand on the door. I am not in and out of the room. I sit down. And through that experience, I understand at a level that you cannot understand unless you've done this, the human condition and the deep empathy it takes to take care of someone as a whole person. And so for young people going into this, yes, there's a technical side that's so cool. Everybody on their surgical rotation wants to be a surgeon. But I say frequently, I can teach anybody to be a technician in the OR, someone to do the procedure. Being a surgeon is very different than that. Being a surgeon is the people part of the technical work.
So before we started today's recording, you kind of asked me, well, this is a little interesting that I'm going to be talking to a bunch of urologists through this podcast. Do urologists really care about whole person, treatment of patients? And I think that's our kind of vision of a lot of surgeons. Is a lot of surgeons, surgeons might not care. Do you think it's that they don't care or they don't have the time in their practice? What do you think that barrier is? And how do people, because we all go into medical school wanting to practice whole person care, and yet so many of us never actually have that opportunity. What is that barrier?
I don't know that all of us go into medical school wanting to have whole person care. I find that a lot of medical students, because I've been an academic for many years, don't actually know what it means to be a doctor because either they've seen their parents be doctors and they've seen the busy part and they're smart kids and they're pushed to that, or they've gone to the doctor. I think that people choose to go into medicine because they have an altruistic heart. But I think many surgeons in particular are captured by the technicality of it, right? I mean, it is cool to command an OR and be technical. I think that's cool. So, not to challenge that insight, but maybe people don't even know what it means to be a whole person, right? Because I get pigeonholed a lot. People have a hard time understanding that the patients don't have a hard time, but other surgeons like, what do you mean? Why would you ask that? Why do we care? Blah, blah, blah. Because if there's a metal to be put in, let's go. And that sounds like really negative. It's not meant to be. It's realistic. I've been doing this a very, very long time, right? So your question, do we have time? Or is it even our culture is legitimate? Because what do we reward medical students for? Or what is the biggest I have never heard a medical student say, a surgical medical student, "I wanna spend more time in the pre-op clinic." Never have I heard that. I'm like, this is what I hear, "How can I get out of this clinic and into the OR?" Right? So it begins young in us, right? And then when we get out into the reality, the most patients I ever saw in a day for many years was 67. How do I, in my academic practice, how do I truly care for the whole person when I must meet some RVU standard that requires me to churn and burn? But I wasn't even the busiest person in my practice. I had a senior surgeon I worked with. He saw 97, 100 people in a day. I don't know that that's good for him or me or the patients, right? And so, is it the world we live in? Well, in an RVU-driven world where depending on your contracts, surgeons like you and you've probably been in school as long as I have with 18 years of formal education, higher education, get paid less than a massage therapist. It's a strange world, and it's what's making great doctors like you, and to some extent me, leave the traditional model, frankly, just to keep the lights on, you know? So, do I think it's about time? Probably. Do I think it's about the model? Probably, but it's also about the culture that we raise our doctor children in.
So I think part of your message is that for young, impressionable people, they have to find those experiences where they're going to be working with vulnerable people, where those relationships in the middle of the night when, you were pushing chemo as a nurse and they're having these deep conversations, they need those early experiences. Is that part of your message?
Part of the message is that just staying connected to people, right? People are not objects of your procedures. People are individuals suffering.
Well, that's a beautiful message. Okay, so continuing on with your expertise. So then you
Mhm.
decided to go to medical school, and you were at the University of Chicago, did residency at University of Pittsburgh, and then a
That's right.
fellowship at the Hospital for Special Surgery in New York. And then
Yes,
you spent much of your career at the University of Pittsburgh.
that's right.
So can you talk a little bit about your research interests while you were there?
So, my career there was a great opportunity. I was surrounded by brilliant people, and our chairman filled our environment with other innovators. So, I got a call during my fellowship that this was so long ago. It seems common now, but at the time, there were maybe two or three prominent hip arthroscopists in the country. It was a very new field. And I got a call from my chairman while still in my fellowship saying, I want you to come back and I want you to do hip arthroscopy. Well, I hadn't been taught that in my fellowship. There was one fellowship in the country for hip arthroscopy at the time. And so, I'm like, I'm still in my fellowship. I don't really want to learn a new skill. It's harder than knee arthroscopy, blah, 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 all the things. But then I realized that from the business side or niche side of orthopedics, I was about to return to a university with some of the best knee and shoulder surgeons in the world. And that's not hyperbole. That is research driven, award winning, best surgeons in the world, right? And so I thought, how is a young surgeon going to come back there, no matter how qualified I am? I mean, HSS is the number one fellowship in the world. I come from a good place, but how could even I distinguish myself? And you know what? It was by learning, by accepting the risk and challenge of learning a new skill immediately. So I learned to do hip arthroscopy. I was Because I was an early adopter, I could make my way in it, I could help develop new instruments, and I came back to the University of Pittsburgh, and I inherited the practice of one of the giants, of Mark Philippon, who with J.W. Thomas Bird, who was at Nashville at the time, Mark Philippon was at Pitt. Mark Philippon was about to leave Pitt to go to Vail, and so I stepped right into his practice, assumed taking care of his patients, and really grew it, and was the only hip arthroscopist there for many years until some of my fellows actually came back to do hip arthroscopy. So I even forget what the question you asked me was, but that's what my research. So I came back to do hip arthroscopy, but and I did some research in that, but a large part, most of my academic research was under the banner of a group that I formed called the Performance and Research Initiative for Masters Athletes, because I refused to believe that life ended at 40 for people being athletic. I was surrounded by great examples of people living healthy, vital, active, joyful, and yet the myth in pop culture was that aging was an inevitable decline from vitality and youth to frailty. And I knew from my own life, from the life of watching my father, who's an endurance athlete across his lifespan, and taking care of master's age athletes, which means you're over 40 and out of the Olympic pathway. I knew that couldn't be true. So, under the banner of Prima, we did a series of studies over the next 15 years, both clinical studies, laboratory studies, that dispelled the myth that aging had to be an inevitable decline. And so some of that work, due to, I didn't promote it this way, but has become legendary in pop culture. I have a study that we published in 2011, which is 3 pictures of axial cuts through the quad of master's age athletes. And, it's one of the studies that helps me summarize in a forum like this. You can retain your bone, you can retain your muscle, you can retain your brain. You do produce more clothes, though, the longevity protein. And down to a cellular level, down to a stem cell level, we can rejuvenate our stem cells with things as simple as chronic mobility. And our work was complementary to the work of other researchers in the space who really were dispelling the myth of aging in this country.
I love that. Now, when I was at the University of Iowa, and I was there for about 5 years, I
Mhm.
actually worked with quite a few sports medicine specialists. And I never knew there was going to be so much overlap between different types of bone doctors. But today's episode is really to all the bone doctors out there, right? The orthopedic surgeons and the urologists. And one of the things that I was working with my orthopedic colleagues at the University of Iowa was on men presenting with chronic scrotal content pain, because we had this hypothesis that the shared patient was the guy presenting with groin pain. And I remember sitting in a room, I had about 25 people in the room, all different specialists. And I said to the group, and I had like 5 orthopedic surgeons there. And I said, I have a hypothesis. I think we're all seeing the same patient with groin pain. And I think it depends on the questions we ask him if he shows up to a place, let's say like urgent care, and how he verbalizes his concerns. So an example would be, guy comes in with right groin pain and the healthcare provider asks, what were you doing before you had the pain? If he says he was on the squat rack, he's going to a sports medicine specialist. If, God forbid, he says the pain radiates to his right testicle, he's going to a urologist. There's no part of the evaluation that overlaps. And the treatment, there is no part of the treatment that overlaps between those two specialties, but it's all the same patient. And it was funny because after I said that, the young, hip orthopedic surgeon said, Amy, I don't believe you. I don't think they're all the same. And a pelvic floor physical therapist raised her hand and said, I see all your patients and they're all the same. And that was actually the start to the first prospective study that I did was in collaboration with orthopedics. I was doing provocative hip maneuvers because I thought I could just hold a person's hip, shake it back and forth and say, does that hurt? Well, apparently that's not how you actually assess for hip pathology. So we had a lot of shared, collaboration there. But the other thing that I was working on with my orthopedic colleagues was like the middle-aged person who comes in with non-operative joint pain, who let's say is not a candidate for or doesn't want a joint replacement. How are we helping that person recover, right? And so you've really delved into helping the middle-aged woman with like musculoskeletal syndrome of menopause. What are your thoughts on just like the middle-aged person, like man or woman who comes in who has some aches or pains? We see those patients all the time. Oftentimes they're presenting to us, do I have low testosterone? What is your message for that typical person in terms of like what they should be doing to optimize their vitality in terms of movement and nutrition?
That is a really broad question.
Like the typical advice for like a middle-aged person who comes in.
There is no typical Amy, there is no typical advice, right? I don't do typical because every person deserves their own evaluation, right? So and I don't only treat women. I mean, I'm an elite sports doctor, so the majority of my life has been treating men's sports, actually. So I treat both men and women. So if a man, for instance, comes in and he has tennis elbow and his IT band is hurting, and we have multiple tendinous sites going, or his Achilles tendon is sore when he plays basketball, or he's jumped up and he's ruptured his Achilles out of seemingly nowhere. When I have a midlife guy with multiple tendinopathies or multiple areas of pain, my first question is, have you had your testosterone checked? Because there are lots of studies within the orthopedic literature citing that multiple site tendinopathy has to do with the gradual decline of testosterone. Frankly, and I say this all the time, and I have 4 sons. I've encouraged them all to do it, and I think they've done it. To get a baseline testosterone in your youth, whenever I catch them, we do it because just because a testosterone in midlife is 600 or 800, which falls squarely in the middle of the normal range, it might have been 1,025 when he was a young man, right? And so a dramatic drop like that is physiologically different for him. He doesn't have to get below 250, which is the norm on the lab panels that I do, to be deficit according to what he was when he was a young man, right? So that's where my brain goes when in my clinical practice I have someone presenting like that or hip pain. I'm very specific about it. And, people are like, oh, my hip hurts down to one finger. Where does it hurt? Because I kiddingly say there are 92 structures within this area of your hip, and we have to get specific because some of them are 1 centimeter away from each other. So this global, my hip hurts, is insufficient for a hip arthroscopist or a true hip and pelvis type doctor. So, if the pain is truly in the groin and I can reproduce it by loaded flexion internal rotation and it feels mechanical like popping, clicking, catching, that says something different to me than no, it doesn't hurt with that test, but I've got this radiating pain from my groin to my pelvic floor. I'm like, what's up with your pelvic floor? What is the nerve entrap or weakness or nerve entrapment? And so I don't have typical advice, but those are some examples with some urology type applications.
Yeah, so you mentioned that you would check someone's testosterone. I've never heard an orthopedic surgeon say that. So you learned that as part of was that part of like fellowship or you just caught on after a while?
You have to remember, Amy, I'm a generation ahead of me, of certainly you, and so the enlightened people like you probably do it all the time. Maybe my young colleagues do it, but in my generation, nobody did it. But I became aware of it. I mean, and the papers are published by the doctor I'm about to quote to you. I had a colleague, we were in the same residency class, who was a professional bodybuilder. And so it was his his hobby, his job, his everything. He was a gymnast in college, a level 1 gymnast, a division 1 gymnast, and then in residence, he began training as a bodybuilder, and he was the first to teach me that this was going on. He published the papers with testosterone and Achilles tendon, Dr. Victor Prisk, who practices in Pittsburgh. So he he taught me, but since then, there's a lot of work surrounding this within orthopedics.
Oh, I agree. I mean, that was the work that I was kind of working on with my colleagues was for the person who presents with non-operative joint pain and he has low testosterone and I treat it. Can I help this guy? So then what would you do? So let's say you find someone who has low normal testosterone. Who are you working with? Or is that something that you're treating? Are you sending them somewhere? How do you work that into your clinic?
So I am likely to prescribe myself for the person who is out of their reproductive era or wants no more children, or because there are implications, obviously, these are urologists. But normally I refer them to a collaborative urologist. And so how I do that is, and it goes back to being a sports doctor, and there's a difference in orthopedics between being sports fellowship trained and being a team doctor. So many sports fellowship trained doctors do the sports procedures, but they don't take care of big teams. So those of us who take care of big teams, what we do is usually it's either a joint relationship or the orthopedic surgeon is the captain of the ship. But we build around this us a deep network of collaborative physicians who understand the athlete, understand timing of the games, understand return to sport, but will answer the cell phone because that's the way we function with elite teams is we never say, "Oh, go find yourself a urologist." We say, "I'm gonna send you to Amy. Here's the time you go see her," right? That's what happens in my everyday clinic now is I say, "Go see Doctor so and so. He's gonna take care of your testosterone." And it is not a foreign concept to the people who come to me. They're like, "Oh, yeah, right. Let's go do that." So, there's no convincing needed, actually. So that's how I handle that for those who need it.
Problems, and if you don't, I'll see you next year.
Mhm.
So it's like this person that doesn't have a diagnosis that I'm sure you see quite often, who just wants to perform better when he's exercising and wants to maintain his health span as long as possible. But let's say his testosterone level is technically normal. Let's say it's 350. How might you help that person in particular?
I think 350 in a man is low. I'm not a urologist, but I think it's low. So, lots of people come to me, men and women, and they are exactly what you said. They're fine. My health is fine. My doctor says, "Here's your labs. Here's your stack of lab papers. You're okay." Well, there's a difference between fine and optimized. So, I have a business called Precision Longevity where people come to me for just this. But what they come with is having read something on Google about rapamycin, methylene blue, and they want to go from where they are to doing all those things, which I'm not opposed to, but that is not my pathway because all of those interventions are evidence influenced, not evidence based. And if we eventually get there, and I'm going to tell you the pathway, if we eventually get there and you would like to participate in treatments that only have rat data, okay, it's your life. And I can explain to you what the data says, what the position is, and what we think might happen. But if you come to me as fine, I am not going to offer that to you because what we know and what we agree on to the doctors in the longevity space, the actual doctors in the longevity space, agree that we can get you 90% of the way there by optimizing your health and adopting some peak performance lifestyle habits, the ones that we prescribe for our elite athletes. So fine is not enough. We optimize. So I start with a big panel of standard labs and we look at your glucose sensitivity. We look at your body composition. We look at your lactate threshold to see where your heart rate, where your metabolism is most efficient. And from a variety of data, there are many things that I do. We develop a lifestyle plan which may or may not be supported by a very small supplement stack, but certainly not a supplement stack that costs $2 million a month to optimize you. And then we spend whatever time it takes 3 months, 6 months. And the truth of the matter is, even when people are motivated by a desire or motivated by how much money they've paid for the plan I developed for them, there is still a significant portion who want to jump to easy and not durable, and they jump off the plan. And that's just human nature. That's why we make resolutions January 1st, and by January 17th, we're done with them, right? But that is not how professional athletes live. Everybody wants to live like their hero, right? Everybody aspires to be that guy or that girl. Their optimized lifestyle and performance, peak performance, is a daily lifestyle, true investment, all in. And so I take people starting at fine and we work towards optimized. And then when we're optimized in terms of here's how we're eating, here's how we're exercising, here's how we've improved your biomarkers, if they've done that, then we add in the peak performance type things that we might offer to true professional athletes. Often that's enough for people. They don't have to go on and do the untested things, but if they want to, okay, we go that way. This is a long road. Most people coming into our offices saying, "I just wanna feel better," aren't willing to put in all this time. So that's why I start with, let's just optimize you, because when you wake up with energy every day, when you are growing a little muscle because you're lifting in a different way, because you're eating in a different way, when you are perky, or when you're able to actually have sex without assistance, that is enough motivation to keep on this road, to feel amazing. Or as I like to say, when I lift heavy or I'm doing sprint intervals, I truly, for lack of a better word, feel like a badass, even at my age, right? The fact that I can do a Spartan and not die, or sprint, which only 1% of people in my age demographic can do. That's badassery that I want to live by. That is motivating for people.
I love that. That is definitely badasser, and I love that word, and we can definitely say that on BackTable Urology. So I'm gonna pick your brain about a couple things that you just said. One thing that you said was having sex unassisted. And I don't think most people would think that, like, an orthopedic surgeon and a urologist would be talking about how does someone have sex, like, unassisted. Do patients come in to see you wanting to optimize their performance? Are they discussing how that relates to their ability to have sex?
Women are. The
Mhm.
men, I bring it up,
Mhm.
right? If I need to bring it up, but the women are. And I think a healthy sex life is a mental game, not a game, is mental, right? Sex is all in your head. It's just functionally distal. But it's part of badassery, right? We identified as one of the key components of being youthful. Not only the fact that, and I listen, I really know nothing about what I'm about to say, but penile turgor is an indication of heart disease, people. So if we can't do that on our own, we have to not just accept that as a reason for Viagra or Cialis or whatever the 29 ED drugs that we've developed for men, but we have to go back and think about what our heart is doing, right? People don't do that. They don't think about what this really means. They just think it's about performance, right? And so I view it as a health indicator, and for women too, right? The benefits of having a healthy ability in that area is actually a life vital sign.
Absolutely. So when the women are coming in and they're bringing up their sexual health concerns related to performance, is it in the setting of them having joint pain that precludes certain positions, or is it stamina?
Okay, number one, nobody brings it up. Everybody is ashamed of how they're feeling. They cannot observe how they feel as objective. There's always some kind of emotion. So, I'm an orthopedic surgeon, and so when people come to me with a frozen shoulder, or I'm gonna caveat, now people know me because of the internet, and they know what they're getting when they come to me, right? So, but if they don't and they come to me with a frozen shoulder, I had 2 women last week. They just looked exhausted. I mean, they're walking just done, exhausted. Life is a lot. But they came to me for a musculoskeletal ache and pain, and they would be euphemistic and say, "I've just got a lot going on right now." This the key word, some very personal things going on right now. And so I know exactly what that means. And so we start talking about, I bet you're not sleeping. I bet this is going on. What about this? And I said, and when I'm listening and she's nodding her head, sometimes crying because no one has listened to her before about this. And then I say, and you know what? Life is rough when sex feels like razor blades, but we can get in front of this for you. That is the door opener that makes people say things like, "You are saving my life." I am not saving their life. I am not a critical care doctor, but when you give them their life back, when you make them feel as vibrant and I don't even know the words, you make them feel like everything is possible again and sexually attracted to people they love, that is something we're saving for people because I believe and research shows that 50 to 73% of midlife divorces are due to the exact things we're talking about now and partners not understanding what's going on with each other in life. And unlike men who have 29 options for erectile dysfunction, as well as implants that you can surgically implant to at least make the parts work, there are two for women, two, and most women don't know about them. On top of the fact that physiologically, when estrogen walks out the door, which starts sometimes in the mid-30s, right during reproductive years, it starts much earlier, and your vagina is atrophying and your labia minora disappear, they retract, which are tissues that can engorge. I mean, I'm talking urologist. It feels silly to say it
I
out
love
loud,
this.
but
I feel like I'm talking to a fellow
yeah,
urologist.
people, please understand what that means to a woman to lose her labia majora and to have sex feel like razor blades, and your partner is not likely to understand. They're gonna view that as rejection or disrespect, and that's usually not what the woman is doing at all. It is self-preservation not to be excoriated during an act which is supposed to be pleasurable, right? So by giving women words to what's going on, by saying, "You know what? I'm gonna get you some vaginal estrogen today. There is no risk of breast cancer. There is no systemic absorption. Slather that on, and we're gonna take care of the gynecourinary syndrome of menopause, plus bonus, fewer bladder infections, which 30% of all women die with. So we're gonna save your life, we're gonna save your sex life, we're gonna prevent your labia minora from reabsorbing, your anatomy changing." Frankly, it replumps up the labia majora. I mean, the whole perineum returns to towards a youthful direction by some vaginal estrogen. Can we just start that if you feel uncomfortable with the whole other spectrum? I say this to orthopedic surgeons. If you would just listen and do this one thing for women and the men that they care about, if you care about business walking in your door, you will be overflooded because you're listening to people, you're solving a real problem that doesn't involve taking them to the OR, and people deserve to be listened to.
So, Dr. Wright, when you say that to your orthopedic colleagues, what is their response?
Well, few have allowed me to say it to them. You know, they know I talk about this. I've invited myself to do grand rounds in many departments, but it's hard for them to see the connection. Honestly, maybe it's my fault. I have not said to them, "I'm going to teach you how to take better care of your men, the vital athlete person." What I do say to them is that 51% of all people in the world are women. Women control 80% of all the healthcare decisions in this country. So if you treat the women well, you will get their whole families. And I say that if you would just let me teach you about the musculoskeletal syndrome of menopause, which affects 70 or more percent of all women in midlife, instead of having a midlife woman with vague pain in your office that you can't do surgery on and you turn them away or you say it's just part of aging or you're rude to them or you roll your eyes or you're like, I don't know, go to your gynecologist. If you would just take the time to understand the musculoskeletal manifestations of menopause or let me teach you, I would then publicly say to the 2 million people I take care of on the internet, Dr. So and so is going to understand because I taught him, and it would fill his office. Few people have taken me up on that. 3 groups have taken me up on that. It gets back to the question about narrow tracking when we're in medical school, right? We get on such a narrow track. We're so driven by the procedure, which frankly we're not being reimbursed for anyway. So you can stay here and be paid $90 for an office visit, which is less than a massage therapist, or you can think about how can I take care of the whole person and still be a surgeon and still keep the lights on in my practice. I mean, I think a smart innovator thinks that way.
So I want to go back to this middle-aged person that would come in, man or
Okay.
woman, and I'm sure that you see people that are on hormones and not on hormones. And I know, like, if I go back to my time as a urology resident, like you mentioned, as a medical student, I don't want to be in clinic. I wanted to be in the operating room with a scalpel in my hand. So intuitively, I didn't like seeing low testosterone patients because I knew I would never operate on a patient who had low testosterone. That was purely a clinic visit. So from an orthopedic perspective, in terms of the person who comes in, who's middle-aged, who wants to perform at their best, and you compare, let's say, the same 45-year-old guy with a testosterone of 350, the guy who starts testosterone, and the guy who doesn't. From your perspective, how do they do differently?
From a surgical perspective or a I feel great in life perspective?
From both perspectives.
If I have a guy who has really low testosterone and has a tendon injury that I've had to fix, I send them to talk about testosterone replacement because it's going to help him heal faster. He's going to have the energy back. He's going to build more muscle. So if I find that, I send them for that. From a lifestyle, from a vibrancy perspective, I mean, I also suggest not only testosterone because that's just your hormone. Unless you lift heavy, unless you are doing your cardio in a way that's not going to break you down, but is really going to be effective, like a pro athlete would. I'll give you an example. Then you're not going to see all the gains you want because testosterone alone is not the magic bullet, right? We know plenty of 30-year-olds with plenty of testosterone who feel shitty or who are suboptimally from a lifestyle perspective. But so for instance, let's take the midlife people, a lot of them. My office, I specifically placed in a performance gym. It's like a Taj Mahal of performance. And my office windows look out onto a indoor football field. That football field is filled with people in group classes doing mid-intensity training every single day. Here's what happens when that's not what pro athletes do. Pro athletes have low intensity days, they have really high intensity days. And it is not 80% high intensity, it's about 80% skill and low intensity and recover. And then, but that's not how mere mortal athletes think we have to do it. They think they have to be high intensity, but not really high intensity every single day. And what happens to midlife people is you start to break down and you start to get injured. And so my goal when people come to me for care is to personalize their exercise regimen according to their lactate threshold about what lifting heavier means to them. Are you getting enough protein to lift at the rate you want? Are you, based on your biomarkers, are there any deficits in your nutrition that we need to supplement? Because just going out and breaking a sweat every day is not going to get you where you're going. It may end up injured or exhausted.
What are some of your favorite protein options?
Whole food. So the real question is, where can you get the highest quality protein, right? So you can have protein from plants, you can have protein from animals, you can have protein that looks like an animal, you can have protein that comes in a bag. So are you getting enough protein, number one? And does the protein you have, either eaten or from a bag, have the highest percentage of leucine? Leucine is the key amino acid. It's an essential amino acid that is the most powerful stimulator of the mTOR pathway for muscle protein synthesis. And so where do we get high quality protein that contains the most leucine? Well, the answer is mother's milk. So most of us are not going around drinking mother's milk, I hope. So the next best source is whey protein isolate, right? So, and whey protein has between 10 and 12% leucine. in it, right? So you can get your protein from plants. I mean, all the vegans out there, back off. You can get it from plants. But in the same way that a dairy cow or a dairy bull, to build the muscle that we value so much, has to eat all day long. You can get protein from plants, but you have to eat a lot of plants because the leucine content in plants is about 6%. So go ahead, get your protein from plants, but please, you have to eat a sufficient amount, which you can if you get it from, say, beans or avocados or legumes or tofu, for instance. You can get high protein content. So, my favorite is whole foods. It doesn't have to be high volume. For instance, a cup of egg whites has about 25 grams of protein, not a high volume. A cup of Greek yogurt has about 20 grams, which is great. An ounce of any animal protein, whether it's fish or beef or chicken, has between 6 and 8 grams of protein, which is a little higher volume, right? A high quality whey protein isolate supplement usually has 20 to 30 grams, depending on who you're eating. And so with that kind of diet, you can get adequate protein, but you just have to be conscientious because I find for both men and women, especially those who choose to intermittent fast, they're not getting enough food, number 1, and protein, number 2.
It definitely takes a lot of thought. People definitely are not eating enough protein. They have no idea how much they're eating.
I think it takes awareness. Once you start, the way I do it is have people start tracking with a simple app. I happen to use my Macros Plus. You can do MyFitnessPal. But once you start plugging in what you eat, very quickly you memorize what has what, and it becomes easy. I don't plug it in anymore. I know what I get in my average breakfast. If I make a shake with these things in it, how much protein I get. So it just takes a little bit of consciousness, but not a ton of work once you're doing it.
So, another question that I'm sure both of us get asked very often in our clinics is what supplements do you recommend? And you talk a lot about the power of creatine. Should most people be on creatine?
Well, a little history on creatine. I first became aware of it in 1992. I was involved with USA Wrestling for the Olympics at that time, and we started doing high dosing in cycling on and off for those athletes. Since that time, it's become one of the most studied dietary supplements, and come to find out, it has benefits for the brain. There was a new Alzheimer's study that just came out last week. Benefits for the brain, benefits for metabolism, benefits for muscle. So, for assisting in building muscle, the recommended dosage is 5 to 10 grams a day, daily. With that low dosing, you don't really have to cycle it. It's okay to do it daily. And so I do it myself. I recommend it to the people I care for as a way to support the muscle building that you're doing. Again, no one thing is going to work. A high protein diet will help you build and retain muscle versus a low protein diet, but protein plus lifting is the optimal. So it's not just protein, it's not just creatine, it's not just hormonal replacement. It's a lifestyle, and it sounds like a lot, but it actually isn't. If you're sitting on the couch, not doing anything, feeling terrible, just layer on one behavior at a time. And there are some people I start out with, can you please just take a walk every day? You've been doing it since you were 1 year old. You know how to do it. Can you add a few jumps to it at the end? Then can we really examine how we're eating? And so we just layer on these behaviors so it becomes how you live, and it takes very little energy. Sometimes when I'm out to dinner with people, they feel strange ordering what they would order in front of me. And they're like, "Oh, you're out. I thought you would splurge." And I'm like, "Well, this is just the way I am. It's not a special behavior." So we layer on lifestyle so the behaviors become non-special, but it's a lifestyle. It's not a gadget. I view gadgets that people sell at longevity conferences as augmentive after you establish your lifestyle, like sauna. I mean, who's not up for a great 40-minute hot sauna? That will not take the place of getting enough protein, lifting weights, hydrating, sleeping, right? It's augmentive. that alone will not get you there. So that's just my approach. But you can envision why a regular urologist or a regular orthopedic surgeon cannot do this in an office visit that's 15 minutes. And I think the general public, including all the executive business people who assume doctors have the ability to do this or are being paid for our time, realize that because of the insurance structure in this country, it is not possible in a standard model. And when I tell this to the executives that I work with or any business person that will listen to me, they are shocked and appalled. I say to them, imagine if you sent me a bill for $5,500, which is what I charge for an ACL, and you sent me a bill for that, and I decided, maybe I'll pay you $700 for 4 months of work. They are shocked and appalled that that is the world that doctors live in, and therefore can understand why you have jumped off into a different model and why my longevity practice has jumped off in a different model. And I rationalize it as, those men and women, those fancy shoes you bought or that new whatever sports equipment or new purse, which is more important, your life or the Birkin purse? To me, it's that crystal clear.
So you mentioned your longevity practice, and I know you've been to longevity conferences, and you probably don't see that many of your surgeon colleagues at those conferences. What would be your recommendation to urologists listening who might be interested in learning more about this whole person-driven care? Should we be going to these conferences?
I think the first thing for a urologist who's thinking about it is to get their own health optimized. Because if you're a typical surgeon, you start out youthful, vibrant, vigorous, no neck pain from leaning over an operative table, and surgeons don't age well. I mean, it is not uncommon for surgeons to die younger than the general population because we've spent our lifetime taking care of other people, eating graham crackers and peanut butter in the surgeon's lounge and never getting outside before dark. So my suggestion is to get your own health in order, and in doing so, you will learn about the key elements that have saved your own life so that you can come at this with an authenticity that your patients will see. And then once you've done that and feel like you need a deeper dive, there are integrative medicine programs. There's a new curriculum being put out by a group called the Longevity Docs, which I belong to. There are great courses. You've taken Rachel Rubin's course, Heather Hirsch, who's an internist who has a whole series on care of the midlife woman surrounding menopause, osteoporosis, musculoskeletal syndrome of menopause, those types of things. Because I'm going to tell you for sure, you are probably not going to get it from your societies. You're not going to get it from the Orthopedic Society. You're probably not going to get it from the National Urology Society. I mean, but you have a gem in your own midst. I forget his last name. Everybody just calls him Mo, which is testosterone
Oh, Mo
expert
Kira.
of the world. Yeah. Testosterone expert of the world, plus very pleasant to listen to. I mean, those kind of resources. But that would be my advice. Don't jump into this unless you've got your own health optimized.
Yeah, that makes sense. Sometimes it's easier to give other people advice than to take our own advice, right? Or to learn what advice to take for ourselves.
And more than that, surgeons aren't always the healthiest people. I mean, two of my orthopedic mentors died right after they retired. That's not the way it should be, right? And no fault of their own. It's just they had these circumstances, but surgeons don't age well.
So we oftentimes try to do everything ourselves, but as you alluded to, in 15 minutes, we simply cannot. You're releasing a book this summer, Unbreakable.
I am.
Yeah. So instead of us feeling like we have to do all of this education, maybe sometimes our exit strategy is to direct people to the really good online content and books to read. What are you hoping that people will learn from your book coming out this summer?
Yeah, so at Unbreakable, here's a galley print. I just got this. The galley print is within the menopause and midlife female space. There are some really good resources. And I don't have a 30-second out the door because I sit and write out notes for people, but the resources I give them, I'll just tell you. I tell people, please read Estrogen Matters. It's the world's literature on the safety of hormone replacement therapy. So estrogen matters, number one. And I tease people, I'm like, if you're an accountant and you love the data, you need to be able to quote it, read Estrogen Matters. It's the book that saved my life. Number one. Number two, there are a lot of good menopause books out there. I think a great one, which is 30 Weeks on the New York Times bestsellers, is Mary Claire's The New Estrogen. I think a great book on female sexuality is called You Are Not Broken by Kelly Casperson. But my book, Unbreakable, picks up where those end. Because, okay, if a woman or the person who loves her is, okay, I got menopause, I've read the data, I'm understanding my sexuality, what do I do next? That's where Unbreakable comes in, because Unbreakable is a science-based book that takes the hallmarks of aging, which I call the time bombs of aging, and teaches you both the physical and mental resilience and lifestyle so that you can have an unbreakable future and not end up frail. So it includes the science, 3 chapters on mindset. It includes how I prescribe exercise and mobility for my patients. And it includes several workouts that were my own workouts, designed for me and the type of thing I prescribe for people, as well as recipes to get started with. Because what I want at the end of this book is for people to really understand how to go strong, to live long, and frankly, to age with power. Because the thing I want at 97, which is my target minimum age, I want to be able to do what I want when I want it. And to do that takes a lifestyle now. The added bonus of this book is it is the first book, in my opinion, objectively, on longevity for women. Because here's what's happening is when we think about men living longer, we call it longevity, and all the bros in my space are writing all these books from the men's perspective, which is fine. But to a cellular level, men are different from women, right? And we all deserve to be treated differently. So, and in pop culture, when you think of a man living longer, I mean, I use him frequently. When George Clooney turned 60 2 years ago or so, he and Brad Pitt put on some great looking clothes and had a photo shoot in GQ in the south of France, right? That is the picture of men living longer. When women want to live longer, it's described as anti-aging, women becoming haggard and non-vibrant, as if there's something wrong with us. There's nothing wrong with us. We're just aging, right? So my goal is to pivot the public narrative on women living longer in the same way that not in the same, in a better way than we describe it for men. Because I know plenty, including myself, of vibrant women in midlife and beyond who I'm capable of doing. I can't think of one thing I can't do now that I did when I was much younger, except have babies, and I'm done with that anyway. So it's okay with me that that's not part of my vocabulary.
I love that. I'm going to have to check out that book. And you mentioned that the decade of the 40s is like one of the greatest decades in a person's life. And that's where people need to get their shit together.
Yes, I call it the critical decade. From 35 to 45 is the critical decade to get your shit together. Whether you're a young doctor in the first 10 years of your practice or the people you treat. And here's why. Socially, you're probably done with your education. You've moved out of your parents' house. You're making a little bit of money independent on your own, right? So socially more stable. Maybe you've developed long-term relationships, right? More stable. But from a health perspective, you still have vibrant stem cells. You are still making enough estrogen, progesterone, testosterone before in men, the slow, steady climb decreases, and in women, the precipitous drop happens. It's critical to get your health practices together because what we're trying to avoid is for women is the devastation, the feeling not like yourself, the profound health consequences of losing your estrogen.
So I think the message for this podcast, and it may have less of an impact maybe on the patients that we see, but this is a call to action for the people watching. My fellow urologists, we are in our 30s and 40s. We are middle-aged. Middle age is not 50s. We are middle-aged. We need to get our shit together starting now.
That's it. And I'm going to give you a pass because surgical residency is no joke. But once you're out, you will not have the career that you desire unless you take care of yourself.
Dr. Wright, thank you so much for joining us today on the BackTable Urology podcast.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, DM us at _BackTable Euro on Instagram, LinkedIn, or X. BackTable is hosted by myself, Ruchika Talwar,
Jose Silva,
and Suzette Sutherland.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Gabe DeGrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz.
thanks again for listening,